Good morning. I thank the invitation on this particular topic, and I will be limiting myself to the presentation and very basic guidelines on the management. The sequence of things which take place when they acquire an HSV infection, it could be a primary HSV disease which can go into a latent form, or it may be a no HSV infection. This agent, it may aggravate later with regular but recurrent HSV disease. The biggest bugbear of operatic keratitis is the recurrence. In primary ocular HSV infection, it is the first infection in a non-immune host. It could be in the form of blepharitis, incarnation vesicles, conjunctivitis, or a degenerative keratitis. And a recurrent ocular HSV infection, which means infection in a previous sensitized host, it can have different ways of presentations. herpetic laminitis is also not uncommon, where it is localized involvement of the deep stroma and the limbus with adjacent scleritis. We do have an entity of herpetic hydrocyclitis, and involvement of hydrocyclitis is related to glomerular pressure. There is markedly localized edema and moderate AEs. Quite often it is confused with androclosial glaucoma, but it actually, if it is located properly, this is herpetic hydrocyclitis. stool keratitis quite often just as problematic to post-traumatic lesion. If it's a non-resolving keratitis, we need to see at what time we are seeing, whether the patient is already on topical steroids, if it's associated with dry eye, not to confuse with drug toxicity or super infection. When you have different numeric eye disease study trials, which typically show that topical corticosteroids, external keratitis, they do actually improve the recovery, but it was not statistically significant. There was no role of oral acyclovir as a therapeutic adjunct in the treatment of stomatal keratitis in patients considering the topical corticosteroid and topical antibiotics. There was no